Good afternoon. I am Dr. Rowson Masud. Would like to present my case. A history of forgotten valve, or headline maybe a history of neglected valve. 40 years old gentleman with known case of chronic rheumatic heart disease with severe mitral stenosis. He underwent mitral valve replacement at the age of 37 years. Gradually, he feels previous symptom more in last 6 months: shortness of breath, NOHA grade 4, abdominal pain, hepatomegaly, ascites, peripheral edema. 2 months ago, he developed severe shortness of breath and admitted into hospital. Ultimately, he put on mechanical ventilation, but unfortunately, after a couple of days, patient died. What will be happened? Do you have any idea? Is it due to acute valve thrombosis, visitation or infective endocarditis, valve dehiscence or venous formation, that is mechanical valve failure, or other pathology? Let's do some investigation. X-ray test showing cardiomegaly, ECG showing atrial fibrillation, echocardiography demonstrated well-functioning prosthetic mitral valve, but tricuspid valve reveals severe tricuspid stenosis, which was missed in echo, and surgeon only replaced mitral valve. What should be the next step of management? Let's know about prosthetic heart valve. Prosthetic heart valves are two types, mechanical and by prosthesis. Mechanical like ball and cage, which was introduced in 1952 and first implanted by Dr. Charles Hafnagel. Tilting disc was introduced in 59. Bileaflet valve is introduced in 69. Biprosthetic valve is stentless, stented and percutaneous, that is TAVI. This is mechanical valve. This is structure of bileaflet valve, ball and cage valve. This is mitral position, housing, ring, ball and cage, tilting disc in aortic mitral valve position, tilting disc in aortic valve position, bileaflet valve. This is disc, this is flow pattern or hemodynamics. This is biological tissue valve, stented, stentlet and percutaneous, that is TAVI. How to assess prosthetic valve function? By clinical evaluation, symptom, sign, date of valve surgery, types and size of valve. By 2D echocardiography, we can assess type of valve, disc, ball mobility, swing ring movement, bright area and panas formation, any mobile masses. By color Doppler, continuous wave Doppler and tissue and pulse wave Doppler, we can assess color flow pattern, excessive turbulence in flow, that is stenotic, valvular regurgitation, either it is washing jet or abnormal jet. Paravalvular leakage means flow outside swing ring, valvular leakage means flow within the ring. The same way we can assess biological valve. What and how to quantitate? Assessment of prosthetic mitral valve. Peak velocity normal less than 1, suggestive of significant if it is more than 2.5. Mean gradient less than 5 normal, more than 10 significant. Prosthetic mitral valve VTI divided by LVOT VTI, if it is less than 2.2 is normal, more than 2.5 is significant. Effective orifice area more than 2 is normal, less than 1 is significant. Pressure half time, we know that less than 130 is normal and more than 200 is significant stenosis. This is my patient. His peak gradient of 6. If you see pressure half time is less than 130 is normal, but my patient, look, pressure half time is only 50. Mitral VTI divided by prosthetic valve VTI, if you see, prosthetic valve VTI was 52 and LVOT VTI 27. So VTI index is only 2. If it is less than 2.2 is normal. If it is more than 2.5 is significant stenosis. We can assess effective orifice area by continuity equation, by cross-sectional area of LVOT into LVOT VTI divided by VTI prosthetic mitral valve. So all the parameters demonstrate that well-functioning prosthetic mitral valve. What's about tricuspid valve? Tricuspid stenosis causes are primary rheumatic, congenital, carcinoid, antiphospholipid, devastating anomaly, secondary thrombus, endocarditis, intracardiac masses. This is the pathophysiology of tricuspid valve. Tricuspid stenosis is less common in rheumatic heart disease, following mitral and aortic stenosis. Doming of leaflet is hallmark of tricuspid stenosis. Candle flame sign is another diagnostic feature. Look like candle flame sign. Severe calcification, hemodynamics. We know the hemodynamics. How to quantify prosthetic tricuspid stenosis? Peak velocity more than 1.7, mean gradient more than 6, pressure half time 230. We can assess a tricuspid valve area by pressure half time 190 divided by pressure half time. This is my patient. Pressure peak velocity was 2, mean gradient was 9. This is significant. Pressure half time average 240. So all the parameters indicate that there is severe tricuspid stenosis. Severe tricuspid regurgitation. This is look like candle flame sign. Severe tricuspid regurgitation. Inferior vena cava is dilated, non-collapsible, and collapsibility index less than 20. So final conclusion, look signs, symptoms, structural findings, previous echo findings, hemodynamic findings. Take home message, do echo carefully, access all valve, provide all information. Often echo is life-saving tools. If you miss, thank you for patient sharing.
Thank you, Dr. Rowson Masud, sir, for your brilliant presentation.